Dear friends, in this video, we are going to discuss about the various means and approaches for open lung approach and PEEP titration. We all know that open lung approach is a very important strategy in treating the patients of ARDS on mechanical ventilation. And it is also implied that in these patients that considerable amount of PEEP has to be applied. And there are some means to know what is the optimal PEEP. And only when that optimal PEEP is applied for a definite duration, the benefits can be expected. So whenever we talk about this open lung approach, we start by discussing about time constant. We know that the time constant is a product of the compliance and the resistance. And in the lungs, all the alveoli don't exhibit the similar behavior, and they vary in the time of feeling and in the time of exhalation. So an alveolar unit with low resistance and low compliance will fill quickly. These are ones which are known as the fast alveolus, whereas a unit with high resistance and high compliance will take a long time to fill and a long time to exhale. So these are the slow alveolus. Normally, we know that one time constant in a healthy lungs is the duration during which around 63% of the lung alveoli are completely filled or completely exhaled. And we also know that a total of 5 time constants are required for complete filling up of the alveoli or complete exhalation of the alveoli. Now, this is all in relation to a normal healthy lung. In ARDS, why do we want to apply an open lung approach? In ARDS, we know that because of a reduced compliance and clogged alveoli, it is even difficult to ensure that they open up on the time constant. So this is even more aggravated, and even 5 time constants may not be adequate to open up all the alveoli. And therefore, it is important to ensure that we need to apply some PEEP. Now, the application of PEEP of extrinsic PEEP, as we know, comes from the implications of the Henry's law, which states that the solubility of a gas or the solubility in a liquid of a gas depends upon the pressure of the gas above the surface of the solution. Therefore, if we apply PEEP, above the surface of the solution, the pressure increases, and oxygen, which is a gas, will dissolve and will diffuse better. So whenever we apply this open lung approach, we ultimately, what we do is we increase the surface area of absorption, which facilitates the exchange of oxygen for carbon dioxide. We all know that in ARDS, in some areas of the lung, there is a lot of, because of this heterogeneous nature of the disease, some lung regions are relatively well aerated and they participate in the gas exchange very nicely and the exchange is smooth. While there are others which are collapsed or partially collapsed as a result of inflammatory contents within the alveoli or because of the increase in the interstitial pressure and the weight of the lung tissue. So these are the ones which do not participate in the process of gas exchange. And whenever we want to apply the optimal PEEP, we want to ensure that these alveoli, they participate in the gas exchange, they open up, and they do it without the cost of causing any aggravation of barotrauma in the normal alveoli, which are already participating in the gaseous exchange and where excess pressure may be harmful. And this is the reason why we need to titrate the PEEP and we need to check what should be the optimal PEEP while ventilating a patient of ARDS. We also know that in the dependent pulmonary zones, when the patient is in supine decubitus at the dorsal level, the adhesion is poorer. and then in the non-dependent zones at the sternal level. So the effect of the gravity and the effect of the VQ, the ventilation to perfusion, is a determinant factor on the need of PEEP at different parts of the lung based upon the alveoli. Now, what happens to this time constant in ARDS? Now, in ARDS patients, the expiratory time constant typically is in the range of 0.4 to 0.6 seconds. And it is shorter in patients with more severe ARDS, indicating low compliance. And there is only, which signifies that small volume of aerated lung, which is actually participating in the gaseous exchange. So this concept of open lung approach was given way back in 1992, almost 30 years back, where it was felt that the rationale for optimum ventilatory mode, which produce minimal pressure swings during the ventilatory cycles and keep the lung open to or equal just above the FRC level, would prevent a significant depletion of the surface active material. So this led to concept of the open lung, and in order to minimize the shear stress and atelic trauma for those alveoli which are not opening, but the repeated closure and opening of those highly non-compliant alveoli can generate shear forces and can cause damage to them, irreversible damage of atelic trauma. So it was proposed by Lashman that keep the lung open, open up the lung and keep the lung open. So that's how it came as open lung approach. So whenever you open approach, we know that it is in application of it needs to recruit the alveoli which were so far less exposed or participating less in the gaseous exchange, which were not able to participate, and this is achieved through the process of alveolar recruitment. So alveolar recruitment is defined as re-expansion of previously collapsed lung, and by means of brief and controlled increase in the transpulmonary pressure. So this has two fundamental components. One is the pressure that is applied and the time for which it is maintained. If the pressure is applied is optimal, but the time is less, then also the recruitment will not be correct. If the pressure is less and the time is prolonged, then also the recruitment will not be complete. So both are important. Critical opening pressure is low in non-dependent regions, and it is high in the dependent regions. And in between these, there is a territory where it is intermediate. So according to both mathematical and experimental models, airway pressures of more than 40 centimeter must be applied to achieve full recruitment. However, it is not always possible to give more than 40 centimeter because of the other side effects which are associated with PEEP. Now, how alveolar recruitment is performed? There are various strategies have been tried and has been reported. Of the most common and the easy strategy that has been tried in many places, in many studies with mild changes, is what we call the 40 by 40, where a CPAP of 35 to 40 centimeter of water is applied for 40 seconds. And it is this high amount of pressure for a brief period of time. It is expected to open up those alveoli which are collapsed and help in their oxygenation. But the results have been mixed. There has been observation of a decrease in mortality in the protective ventilation group and greater weaning rate initially in the Amato trial without any adverse effects. But these results were not reproducible in other studies. And many people also changed the duration, like some applied 35 to 40 centimeter for a slightly less time, hoping that the side effects will be less. Some applied a little more pressures, and they also expected that probably the benefits would be more. But the results have not been so equivocal. Yet, we can say this 40 by 40 has paved the way to determine at least that for a brief period, if one applies a 40 centimeter or 45 centimeter of water pressure over 30 to 40 seconds, then it is likely to recruit. There has been other methods too, like Pelosi studied, where he applied 3 consecutive sighs per minute at 45 centimeter of water plateau pressure during 1 hour with protective ventilation, and found that there was increased PaO2 and lung volume at the end of expiration, and there was drop in the PCO2, which was greater effect in cases of extrapulmonary ARDS. They also found another study of 3 sides of 45 centimeter during 1 hour with ventilation in prone decubitus, and they found that increased end expiration volume with PO2 with decreased shunt. Although the adverse effects were not there, but actual benefit of this in prone position still could not be defined very clearly. Now, this can be divided into 4 large groups. If you see overall, one is sustained CPAP. The most frequent combination is the application of 40 centimeter of water for 40 seconds. During this time, the supporting pressure must be set to 0 centimeter to avoid barotrauma, and it is the most widely used technique. Second is the application of PSI, where the increased tidal volume or PEEP during one or several respirations with adjustment designed to reach a specific plateau pressure, which can be kept at 30 centimeter. Extended PSI, which is characterized by a progressive increase in PEEP together with a decrease in tidal volume during a longer period of time. This has also been studied, as you can see, by Dyer et al. And pressure control volume, maintaining a delta pressure, usually 15 centimeter of water, to guarantee a tidal volume with progressive increases in PEEP. And this has also been used, as you can see, by Patronitis et al. And Oksinski et al. So these are the different ways or different groups in which one can think about doing recruitment. But there are also some other techniques, ones that include high frequency ventilation, which gives rise to higher mean airway pressures, which limits the cyclical alveolar closure and increases the end expiratory lung volume. Liquid ventilation, that is partial lung filling with PFC, gives rise to progressive parenchymal recruitment. PFC is perfluorocarbons, and that begins in the dependent zones. And ventilation in prone decubitus, that of course has been clearly proven as one of the ideal methods in which recruitment can be hastened by making the patient prone in decubitus, and the distribution of the transpulmonary pressure gradient is altered and gives rise to more homogeneous alveolar filling. So what are the benefits that are caused by this recruitment? So all the potentially recruitable lung can be recruited. As we can see that there is an open alveoli, collapsed alveoli, and areas of lung inhomogeneity. And these areas of lung homogeneity are the ones where the risk of ventilator-induced lung injury is maximum because of cyclic opening and closing of the smaller airways, which is called tidal recruitment or atelic trauma. There can be also local overdistension through the effect of stress raisers. Now, to minimize these areas of lung homogeneity and potentially recruit the potentially recruitable lung, this is possible. So it increases the number of open alveoli by causing reduction of stress and strain, decreasing the dead space, and decreasing the pulmonary vascular resistance. It causes improvement of the lung homogeneity and thereby leads to reduction of ventilator-induced lung injury. It causes decreased number of collapsed alveoli, and therefore produces decrease in the shunt, decreased pulmonary vascular resistance, decreased edema, improvement of surfactant function, and improved oxygenation of the lung parenchyma. However, it comes at the potential risk, that is, open alveoli can worsen cause alveolar overdistension in the normal alveoli. It can worsen the dead space. It can increase the pulmonary vascular resistance, and it can also worsen the lung inhomogeneity because there can be an increase in the number of partially open alveoli if it is not optimal, and there can be increased risk of villi. So there are both potential benefits and potential risks, and all these benefits and risks need to be weighed properly before going for recruitment. As you can see here in the top curve, the change in FRC with the application of PEEP, the PEEP is shifted upward the curve, showing an increase in the volume for the same pressure. Therefore, we can see here that there is recruitment. In the bottom, you see the PEEP shifted the curve along the pressure axis to the right and causing an increase in pressure for the same volume. So here there is over distension. So both recruitment and over distension is possible through and one needs to be careful and identify what is happening. The resting volume is the volume at the elastic equilibrium point of the respiratory system, and the delta FRC is the change in the FRC caused by the different levels of PEEP, which you can see the blue dotted lines are indicating both upper and below. In the lower bottom, you can see it is less. In the upper bottom, in the upper top of in the upper on the lower side, you can see it is more. So these can clearly spell out, or this can indicate whether the patient is moving towards recruitment or towards over distension. Now, what causes variability of response to recruitment maneuvers? One is the origin of the ARDS. Now, differences has been found between ARDS of pulmonary and extrapulmonary origin, and this recruitment seems to work better or has a greater efficacy in when the ARDS is extrapulmonary. Next is the evolution phase. It seems to be effective only when performed in the early phases of lung injury, when it is evolving. Once it has become consolidated or established, it doesn't seem to work that well. Patient positioning, recruitment response is greater in prone decubitors, which itself can be regarded as a form of alveolar recruitment. So these are the simple the points which can cause variability in the response. In addition to that, if you see the vasoactive drug treatment by modifying the cardiac output, the distribution of the pulmonary blood flow and the gas exchange can modify the response to AR. It is very important to realize that whenever there is a PEEP, a patient is mechanically ventilated. So there is a fall in the cardiac output because of impediment in the venous return. So these patients will maintain at the cost of there has to be the increase the systemic vascular resistance. Now, if these patients are sepsis or in some form of distributive shock, where they cannot increase the systemic vascular resistance, probably they will tend to have more severe hypotension, fall in cardiac output, and therefore there will be a reduction in the pulmonary blood flow. So when actually the PEEP is expected to cause benefit because of the fall of pulmonary blood flow, it can rather worsen or aggravate the VQ mismatch. So this also has to be kept in mind. Then the chest expansion capacity. The alveolar recruitment maneuvering seems to be ineffective in patients with limited chest expansions, chest splinting following trauma, etc., thoracic trauma. Previous mechanical ventilation parameters, use of higher tidal volumes and particularly higher PEEP values before alveolar recruitment is associated with lesser response to recruitment. So when is this maneuvering indicated? There is no evidence regarding what concrete moments or with what frequency, but maximum recruitment strategies and open lung theory advocate the early application of ventilation protocols across the different phases. So what are the indicators of positive response to alveolar recruitment maneuvering? One, the PF ratio increased to at least 50%. Maximum recruitment can be assumed with an FiO2 of 100% if the combined PaO2 plus PCO2 is 400, or if the PF ratio is more than 350 with a collapsed lung tissue mass of less than 5%. Increase in oxygenation is usually brief, and the duration of effect is usually 3 to 6 hours. No difference has been observed in terms of the duration of mechanical ventilation, hospital stay, or mortality, or in other words, the outcome is unlikely to be affected by the alveolar recruitment, although if there is an improvement in the oxygenation. So what are the side effects of alveolar recruitment? The most frequent side effect is hypotension and desaturation. The other complications include barotrauma, arrhythmias, hypoventilation, and acidosis. And it has even been postulated that bacterial translocation can occur from within the alveoli. When sustained inflation maneuvers are carried out, the side effects are more frequent than with other techniques. In the case of maneuvering with pressure ventilation, there appears to be fewer cases of barotrauma or adverse hemodynamic effects since maneuvering is applied in a more progressive manner. We don't reach the peak so early. So effects are usually brief and are of scant importance. Now, how to select? Next question is the ideal PEEP. After we recruit the color collapsed lung, we would also require an optimal PEEP to prevent them from collapsing again or to keep them open. So one approach is to use an arbitrarily high PEEP, and which is a lazy man's approach. The CT studies support the use of PEEP of around 16 centimeter of water. And 3 trials have actually examined this, the alveoli, loves, and express. The findings have been compiled into a meta-analysis. So high PEEP groups averaged around 12 to 15 centimeter, low PEEP groups usually 8 to 9 centimeter. Overall, there was no in-hospital mortality benefit, but there seems to be a small mortality benefit for the most severity groups, that is in those with a PF ratio of less than 200. So an arbitrarily high PEEP to use, well, doesn't make too much of sense, but yes, if there is no other means, one can look for it. There may or may not be any benefit. So in this, you set the PEEP to around 15 to 20 centimeter of water. Or in case of ARDS, we can see the ARDS net protocol where the PEEP FiO2 titration can be done according to the table, the escalation tables, higher PEEP to lower PEEP. You can see the ratio. And worsening hypoxia is matched by an escalation of PEEP from a PEEP of 5 at 30% of FiO2 to a PEEP of 20 to 24 at 100% FiO2. If any patient requires 30% FiO2, the protocol recommends a PEEP of 5, which would be a suboptimal level of PEEP for most ARDS patients. Higher PEEP recommendations in the high FiO2 range can account for disastrous shunt effects such as of high PEEP patients with diminished right ventricular function and pulmonary artery hypertension. So these are some of the problems with using this table as well. It is not that this table is foolproof, avoid of any. So the protocol is based upon a consensus of how the investigators and clinical colleagues balanced the beneficial and adverse effects of PEEP in 1995. It cannot guarantee success as of today when 25 years have changed. Our understanding on the nature of ventilator-induced lung injury has changed. So this understanding also requires a revisit. Next, by showing the maximized static compliance. Static compliance is measured at increasing level of PEEP. It is calculated as the VT divided by the change in driving pressure at the end of, or the plateau pressure at the end of 2-second inflation hold. The PEEP is increased in steps of 2 centimeter beginning at 5 centimeter. The highest static compliance is considered to be the best PEEP. Now, as I told you that this is the change in plateau pressure at the end of 2-second inflation hold. Similarly, we can also look into the driving pressure, because as we note as of today that plateau pressure minus PEEP gives the driving pressure. And if we try to reduce the driving pressure so that it is maintained below 15, and if we see that our ventilatory strategy, the driving pressure is gradually reducing or at least unchanged and below 15, then it can infers that the ventilatory strategy is working, and the PEEP at that point of time can be considered also as optimal PEEP. So optimal PEEP is therefore at which the compliance will be maximum, that is increasing the PEEP beyond this magical number will do a little to improve the compliance, and decreasing the PEEP below this value will make the compliance worse. So this is what we call by optimal PEEP. Another way is to find the lower inflection point. You can see the lower inflection point is the one where there is minimum pressure required for alveolar distension recruitment. So this can be seen. So this is the PV loop. As you can see that there you can underline what is the PEEP, the alveolar recruitment and airway resistance, the optimal compliance, the period that lies between the lower and upper inflection point, and beyond upper inflection point, it is the peak, it is the area for alveolar distension. At that pressure, there is actually distended. So in which you get beaking of this curve. So it is very important to realize that when we can choose 2 centimeter, but it is very difficult in practically to you apply this method on the bedside. But however, one may use where particularly where de-recruitment occurs. And in either case, nobody really knows where these points actually are when presented in a real-time PV loop. In order to work properly, this method requires a completely paralyzed patient, and that is also not possible always. Next is the staircase recruitment or de-recruitment maneuver. We ventilate the patient with a CPAP of 35 centimeter of water for 40 seconds, then set a PEEP of 20 centimeter of water. If a minimum tidal volume of 5 ml per kg cannot be achieved, we decrease the PEEP by 2 centimeter until we get the minimum tidal volume, then decrease by PEEP by 2 centimeter per every 20 minutes. Watch the PO2 and observe the PEEP setting results in a more than 10% decrease. The lowest PEEP, which does not cause a greater than 10% drop in the PaO2, is the optimal PEEP. Now, this will require more elaborate understanding, but it will give more clearly the results. Next is looking into the arterial minus end tidal CO2 gradient. ARDS patients will have widened gradient because PeO2 and EtCO2 because of wasted dead space ventilation. So little lung tissue is actually exchanging gas that even the CO2 which is accumulating is unable to escape. So, and what in this connection, I want to add one thing, that in these patients also the work of breathing is typically very high. And because the work of breathing is high, then also the energy expenditure is high. And if the energy expenditure is high, you know that the amount of lactate production and CO2 production is also high. So this is also one of the reasons, because of increased production of CO2 and the limited escape route of this CO2, that this arterial minus end tidal CO2 gradient gradually builds up. So it is postulate that ideal PEEP is the one at which the dead space fraction, that is VD by VT, is minimal. And this is probably also the PEEP at which the compliance can be maximum. So at a certain PEEP, the gradient is minimal, and then the PEEP again climbs, as you can see from this graph, and we can choose that level and use it. Next is CT of the chest, which will show the average PEEP which is required for needed with the patient with ARDS to keep their lung open is approximately the same, independently on the fact that the amount of tissue to be kept open is as low as 3% or as high as 50% of the total lung weight. So high lung recruitability can be ensured in the CT chest, although that is also requires shifting the patient to the CT suit, radiology suit, which may not be always a good idea to do. Then transpulmonary pressure and esophageal balloon, we know that the intrapulmonary pressure or the atmospheric pressure and the intrapleural pressure, which is slightly negative, and the difference between these two is the transpulmonary pressure. We set the PEEP to keep the transpulmonary pressure of about 0 to 10 centimeter of water at end expiration, and set the tidal volume or the driving pressure to keep the TPP of not greater than 25 centimeter of water at end inspiration. So this is how we can measure it. There is an esophageal dilated, this catheter is there, and it is a surrogate for the esophageal balloon pressure. And we can see the difference can be seen to estimate the transpulmonary pressure. So this transpulmonary pressure has the advantage of separating the chest wall compliance from the lung compliance. So if we are guiding this level of recruitment on the basis of transpulmonary pressure, say because a patient with a very big, very hefty patient with a thick, heavy chest wall, so the pure chest compliance, in which although the compliance of the lung may be normal bit, but it will inadvertently show a very high. But if you see the transpulmonary pressure, you can be able to actually measure the required PEEP. Another is the electrical impedance tomography. The electrical resistance of the thorax should plateau at a point where all the recruitable alveoli are recruited. So this electrical impedance tomography is much better at temporal resolution, that is the ability to plot lung function or the lung recruitment versus time. It offers the opportunity for live dynamic lung imaging in the course of mechanical ventilation. So my take-home message would be that Alveolar recruitment maneuvering cannot be recommended as a general practice in clinically stable ARDS patients. Usually, it affords variable and temporary improvement in oxygenation without proven beneficial effects upon mortality. PEEP should be selected as a balance between alveolar recruitment and overdistension. Evidence is not currently available to suggest that any one approach to setting PEEP leads to a better outcome than others. And recruitment maneuvers and PEEP should be used within the context of lung protection. Because if we are not able to protect the lung by making all the other recommendations, then all the benefits of PEEP will go wasted, and instead all the harm will manifest. So, and it is just not just a means of improving oxygenation. Thank you very much.